Welcome to our afternoon session. This is session B4. This is the primary care themed session. I'm the chair for the session. My name is Greg Ogrins. I'm a general internal medicine physician from Dartmouth Medical School in New Hampshire in the U.S. And I have the pleasure of introducing our speakers, and I will be moderating the session today. So we will have our session is scheduled for 90 minutes, and we will have two sets of speakers. Our first speaker will be Iain Smith. We'll talk about Kaizen events in general practice, and he will have about 45 minutes and has some interactive work for you, and will be opportunity for questions after his session. And then we'll turn to John Whittington and
Iain Rutter.
Ian, it's not Doug Eby. Doug Eby's on my list.
Iain Rutter.
Iain Rutter. And they will do the second half of the session. And what we're going to hear, and as a primary care practitioner in the U.S., I'm actually very excited about these sessions and hearing about some of the innovations that they've had in primary care. So with that, let me hand it over to Iain Smith, who will get us started.
Good afternoon, everybody. My name is Iain Smith. I work for a regional improvement collaborative in the northeast of England. I'm going to tell you about that collaborative and the work that we've done, how we came to be doing it, and some of the work that we did in primary care. But first of all, you may have found a small coloured square of paper on your chair. I'd be grateful if you could hold on to that for now, because we're going to use it for a very short practical exercise a little later on, a bit of an experiment, so I'm crossing my fingers that it works. But if you could hang on to it, we'll see how we go. So, my name's Iain Smith. I work for a collaborative. We call it the North East Transformation System. It's based in the northeast of England, and we use lean as our method of making improvements to healthcare. And Kaizen events, which I want to talk about, are a type of improvement workshop that those of us using lean often deploy to help people make improvements and to help people learn about lean and how it works. And for the last 2 or 3 years, we've been using these in small-scale environments like practices, something that's a little unusual and hasn't been done too much. And I'd like to tell you a little bit about that. But first, for those of you who are perhaps unfamiliar with the term Kaizen, I thought we'd start with that. What is it? What is Kaizen? And it's a Japanese word. It literally translates as this: to renew the heart and make good. And that translation, it's one that I like. It conveys the philosophical side of lean and quality improvement. It's something that you live and something that you feel. But a more practical definition is this: to take apart and put back in a better way. And that effectively is what we do in a Kaizen event. We look at something and we take it apart and we put it back, hopefully, in a better way. And Kaizen, the essence of it is continuous incremental improvement on an ongoing basis. So, a little bit of background about the work that I do and the people that I work with. North East Transformation System, NETS for short, it has its origins in the Japanese automotive industry, where lean has its origins. Companies such as Toyota, Nissan and Honda are well written about. Their production systems are very well known for the quality of the product that they output. A lot has been written about them. You may have heard people talk at conferences such as this about those things in the past. And lean has made its way out of manufacturing and automotive into our industry, into healthcare, over the last decade or so. And this organisation, Virginia Mason, that we can see on here, is one of the, I consider one of the healthcare pioneers in lean. Their chief executive is here this week. If you'd like to go and hear him speak, I encourage you to do so. You won't regret hearing him speak. And some 6 years ago now, in the northeast of England, we started to work with Virginia Mason to learn about the lean and learn about Toyota and Nissan and how we could perhaps borrow those ideas and bring them to our context in the UK. And the way we framed it to suit our needs in North East England, we called our programme North East Transformation System. It's our expression of lean in healthcare, and it embodies all the things that we've learned from our industrial partners and our healthcare partners in Virginia Mason. So we describe our net change model like this. We took what we thought were the core bits that we learned from particularly VM and others. So, well, what do we need to have to make a change or to make an improvement? And we start with this idea of vision. And all that really means is having a clear idea of what it is we want to achieve. It's very important, if you're trying to make a change, that you know why you're doing it, and you've decided that it's a needed change, and you've decided where you want to be. You've set yourself some clear aims for the change that you're trying to make. Possibly more important than that is this concept of compact. It's a word that we're not so used to in the UK. More of an American word. Literally means an agreement between two parties. And the agreement between parties when we're making a change is about the clear expectations about what we're going to do. What's the organisation going to do, and what are the individuals going to do? What can we expect from each other? And it's the tricky side of change, the people side of change. There's a very good friend of mine, when talking about his children, always uses the term, it might not matter to you, but it's always life or death to them. Everything has meaning for children, and it doesn't really change throughout our lives. When we come up against a change, it might not be life or death, but it often feels like it. It evokes very strong emotions, and compact is a way about unearthing that sort of stuff and understanding how people feel about existing processes and the proposed change, the people side of change. And the other component that we felt was important was to have some method of making a change. If we've articulated what we want to achieve, we've worked with our people to understand our individual positions and our aspirations and where we want to go, then we need some way to make our change. The method that we use in the North East Transformation System is our healthcare adapted version of Lean. So, brief background to the NETS programme and the NETS model. So, how do we come to be introducing Lean to general practice? Lean, obviously, with its industrial roots, it's used by very large organisations, and when it moved out of manufacturing into healthcare, it moved into similarly large organisations, and most of the literature and most of the work was, can we transfer from manufacturing to healthcare? And the debates were about that. There was very little about, can you move from a large-scale organisation to a small-scale organisation? Even in industry, that kind of research is only just being done now, even though Lean's been around for a very long time. So looking at, can you take it from a large-scale industry to a small-scale industry, can you take it from manufacturing to healthcare, was something that's a little unusual. And in this part of the world where I live, yeah, it's North East England, and if you imagine drawing a line through the lighter green there, in that bottom half, that's where I worked from 2008 until 2011 last year, for a primary care organisation that was responsible for buying healthcare for about 500,000 people, and for contracting with general practitioners and primary care to provide general practice services. And we wanted, as an early adopter of Virginia Mason's techniques, to make that available to our primary care clinicians. And we found from looking at literature that pretty much no one had done this. There's some good literature from other improvement programmes in Europe, in Holland in particular, and UK in the late 90s. And there was a little bit of work in the southeast going on doing similar things, but relatively little about Lean in general practice. So we couldn't really look to the literature too much for what should we do and how should we run our programme. So we thought, well, we'll look into it and we'll see if we can find out for ourselves. We'll just start with what we know and what we've got. So in this part of the world, we were the first, we think, to apply the Virginia Mason approach to UK general practice. And over the course of 2 years, we ran 8 of these Kaizen events, or 8 of the original Kaizen events, with 5 practices, and from what we learned from that, we started to adapt them in the ways that GPs and primary care staff were telling us would be more beneficial to them. So it was my job to design that programme and lead that programme, and I'm going to tell you about what we did and some of the mistakes we made along the way, and hopefully some of the things that we got right. So first of all, you might think, well, what is a Kaizen event? The form that we took was the form that we learned from Virginia Mason before we chose to adapt it. And it very much is a time-out workshop. And this is a key thing for primary care, where time is everything in primary care. It's a very busy environment, high volume of patients, huge variety of different conditions. So time's important to GPs, I found, and is often a barrier to making changes. But Kaizen events require stopping what we're doing, or at least some people stopping what we're doing, to look at something, to make a change, to focus on a particular process. And it's important that the people who work in that process, who do the work, are the people who stop and look at it and decide what it is they want to change about it to make it a better process. So we've got our definition of Kaizen event there. And we found some volunteers from our practices. We have 86 practices in our area of Durham in the northeast. And over the 2-year programme, we reached about half of them in some way. We ran a lot of one-day training programs to introduce lean to them. We ran a lot of activities looking at safer care and how they could measure that and incorporate it within our program. And we ran a lot of hands-on Kaizen events to see if you could do it and how you could do it. And effectively, these events work like this. I'm hoping that many of you will have seen this before, the PDSA cycle and the model for improvement. This plan, do, study, act cycle, this is really the engine that drives lean thinking. It drives much of quality improvement. And all Kaizen events start with a vision or an aim. A clear understanding of what we're hoping to achieve and the problems that we're trying to solve. Usually, you would start with, there's something that's frustrating us, there's something that's not going as well as we would like, and do we want to do something about it? And that will state the focus for your Kaizen event. If you can't state that quite clearly and quite concisely, you're going to lose your way through the process. You're going to find it difficult to get to an outcome that's what you wanted without knowing what you wanted to achieve by doing it. It's important to measure where we are. You're going to try lots of different types of ideas in a Kaizen event, and you want to know, well, which one worked, which one had the effect that we were looking for. And we try to work in a scientific way as best we can to try and select the ideas that seem to be producing the best effect, the best impact. So measuring the right thing is important, and understanding where we are now so we can understand, has this idea worked? Is this idea more effective than this idea? Can we take opinion out of the equation and go for, well, the evidence that we've generated tells us this is working better for us. So measurement's important. And then idea generation and small-scale testing. In a Kaizen event, the people who know the work best need to be there. And when they are released and asked, so, okay, what frustrates you, what do you feel is wrong, and what do you feel you could do differently? These things are, excuse me, these things come out very naturally. Ideas generated quite quickly from problems when people stop to think about what they are. What we encourage people to do is to take debate out of the equation and put trying in. We say it's better to try storm something than to brainstorm something. Often an event can turn into a lot of people talking about, I think we should do this, I think we should do this. But if we just ask them, well, why don't you both go and try those things and measure the impact, and then we'll discuss what we think's worked. And it doesn't have to be in this idea or that idea. We might think, well, this one's working, but are there things we can pinch from this idea to add to this to make it even better? So we try to try things, test things very quickly in the Kaizen event, not in a month's time, in 2 months' time, but there and then, in some small-scale way. The aim is to be, at the end of the event, we've got something that we're fairly confident is going to work well, and we're going to try it for a longer period of time, give it a bigger test, and see what the impact is, and make sure it's right for us. And the structure for this looks a bit like this. There are 3 phases to a Kaizen event, effectively. Not so different to what many of you will do as clinicians every day. There's a diagnostic phase, understanding where we are now, what the problem might be. And so we study and we plan. We study the process and we plan what we're going to do, the workshop, the intervention, much as you would with a patient that comes in with a complaint or a problem. We'll study the patient, we'll try to understand what's wrong. You might take some measurements, and then we're going to choose a course of action, and we're going to implement that, and we're going to see what the effect is. Kaizen Event is much the same, except we do this looking at a process rather than at a patient. The format that we originally used was this. There was a lot of data collection and planning for about 6 weeks before the workshop itself. And this was mainly done by external people like myself and other colleagues who would go into the practice to do the observation, the measurement and the data collection. And then the practice would work with us on a 5-day event, a 5-day workshop, to solve the problems that they'd identified. And then we do some follow-up. The follow-up period's mainly about measurement, but then we'd have some meetings at about 30 days, 60 days and 90 days to see, is it having the effect that we wanted? And we ran many of these, 8 of these in this format, with our most enthusiastic practices, and many of them would say, we're really pleased we did this, we're really satisfied with the result that it's given us, but can we do something again next time that doesn't take as much time? It's quite hard for us to take so much time out of a small-scale organisation. Can we chop some days out? We said, well, yeah, if you think that'll work, then we want to get to more practices. So our first attempt to adapt this was to do just that. We'll chop some days out. We'll do a little bit less on the data collection and planning, and we'll have a smaller workshop and maybe focus on a smaller scale problem. And this has worked quite well for us. It's now been adopted by the northern half of England on our map earlier. They're running this particular model, just what we would normally do, but chopped down a bit. But because we wanted to get to more practices, I felt this was still quite a lot for a lot of practices to do, and I felt there were other issues with this. The fact that an external person went in and did much of this front end was somewhat problematic, because the practices saw us as people who would come in and do this for them, rather than people who would come in and help them to do it for themselves. So we wanted to chop more time out, but retain the essence of a time-out workshop to solve problems, and also change the emphasis of somebody to come and do it for you to somebody to come and do it with you. The idea more of facilitation rather than telling them what to do. So our second adaptation was like this, much shorter data collection and planning period, but actually starting the time-out part of the workshop right at the beginning of the process. So this 1-day time-out was part of the diagnostic phase, part of the study and part of the plan, and putting all of the power for that into the hands of the practice staff. So someone's not going to come in for you and diagnose that this is what seems to be wrong, but rather someone will help you run a workshop where you decide what is wrong and decide what you will measure and decide what your plan is for the do stage, for the actual intervention workshop. And that felt like a much stronger way to transfer knowledge into practices who wanted to do this for themselves, rather than the original format that we were working with. Not that there was anything wrong with that format, but the scale of an organisation, a hospital, say, with 3,000 to 5,000 staff, is not the same as a primary care practice that might have tens of staff, or possibly less. But why should they not have access to the same kind of improvement techniques that hospitals were starting to use? So this is where we arrived, and this worked reasonably well. There's still resistance, of course, amongst primary care and clinicians taking time out. I can't take time out. I can't afford to take time out, and I completely understand that. It's a very, very busy environment, but without taking some time out to make improvement, you can't expect change to occur. So it has to be driven by something that you wanted to change and need to change. But if you choose to go this way, you can make changes very rapidly, rather than, say, over a series of lunchtime meetings where it might stretch out over months or years and you may not make massive changes. So it really is up to you to choose whether this is something that you think is interesting to you or not. It was very much my approach through the programme to not tell practices what they should do, but to let them choose what they wanted to do and to work on processes that mattered to them. So the aims of a workshop have a very short session, and Lean to me is a lifetime learning journey. I've been learning about it for about between 6 and 10 years now, and feel like I'm just scratching the surface. So I've tried to capture what we do in an event in one slide, and we'll use this piece of paper shortly to illustrate a couple of points, and hopefully it will work. You can all cross your fingers. So the aim of a Kaizen event is effectively this: to reduce waste and process variation. All work is a process, effectively, I think, and those processes are intended to deliver some value to the people who depend on them. So our patients depend on us to deliver value to them, value in terms of the quality of care they get, the experience of that care, and an outcome that meets their needs. All processes either deliver some value or they don't. And we can break processes down, we can map them, we can draw them out. That can help us understand what's working well and not so well. Processes have inputs, and mainly the inputs that we have into our processes in healthcare aren't so different to other places, aren't so different in primary care. We have our staff is our biggest input. Our clinical staff, our admin staff, the people who work with our patients are a major input into our processes. The stuff that we use to do our work, the equipment that we have, and the supplies and consumables that we use while we use that equipment and while we do our work. And processes have outputs. Outputs of healthcare processes, we hope we're delivering safe care. We hope it's effective, meeting the patient's needs and solving the problem that they've presented with. And we hope their experience of that care is a positive one. And that's going to deliver a patient outcome. And very often when looking at a process, you might find that there's some variation in it. If we assume that these wobbly lines here represent variation in the process, if we have variation in the process inputs, we might reasonably expect to get variation in the outputs. So sometimes the experience or the outcome is better than other times. And what we're trying to do in the Kaizen event is work with the practice to select something that matters to them and look at, well, what are the outputs and what do you want to measure about those outputs that you feel you want to improve? And if we can measure those outputs, that's going to provide us some feedback that can help us make decisions in our Kaizen event, help them make decisions in the Kaizen event. We just kind of play. We're kind of the referee. We know the rules of the game, but we don't play. We just try and coordinate the game. We can manage the inputs by applying our lean thinking, our NETS techniques, our VM techniques, or whatever it is that you choose to use, whatever seems appropriate to help solve the problem. And the idea is if we have variation due to staff, maybe we ask those staff to say, well, what's the best known way for this particular process? And will you adopt it as a best practice standard? And will that reduce the variation? If it's equipment, it might be we use some workplace organisation techniques to lay things out in a better way, that better meets the needs of the staff and better meets the needs of the patients. Or if it's supplies, if we're running out of things, if things aren't where they should be, if this is frustrating, we might create a more visual process where we can see what we've got, see how much of it we've got, work out how much we need, and create a process that keeps it at that level so we don't have frustrations in our daily work when we've got a high turnover of patients. The idea is if we can reduce the variations in the inputs, we can also add some reliability with error proofing, we can remove waste, and hopefully it will reduce the variation in the outputs and the variation in the outcomes. And variations, it's a funny thing to get your head around. It took me a long time. I'm sure it will only take you about 5 minutes. But if you could pick up the square of paper that you have in your hand, I just want to try something, see if this works to illustrate it. I'm going to do this just down here so you can't quite see. All I would like you to do is follow the instructions that I give you and just do this on your own. It tends to work best if you can. If you could please just fold your square of paper in half. And if you could fold it in half again, please. And one more time. Now this is the difficult bit, and I apologise for anyone who has difficulty with it. Could you tear off one corner from whatever you have in your hand? Sometimes people ask me for scissors for this, but I don't have any. Have we all, or most of us, managed to tear a corner off? Could you unfold what you have for me and hold it up for all to see? I've got this. So if you, it looks fabulous from up here. If you take a look around at your nearest neighbours, do we all have the same thing? No, we've all got different things. So we all, with all of the education that you have followed the same very simple verbal instructions, and we've managed to get very, very different results. And the point of this illustration is, and you can keep them and take them home to remember me by. The point of this illustration is, even with a very, very simple process like that, variation creeps into it very easily and very quickly, because you're not sure which way I'm folding it, and you're not sure which corner I'm tearing off. Very much the same if you think about what you do every day in primary care, how many patients you see, how many different conditions present, how many things you're thinking about. It's so very easy for this kind of variation to creep in and to make your work more difficult, and perhaps make the outputs that much more varied, and perhaps the outcomes as well. So Kaizen Event, they aim to look at these things, reduce waste and reduce variation. So things that we tackled, I say we, the practices we worked with tackled them. Perhaps these are processes that matter to you as well. Prescribing came up a lot. We looked at that several times, at repeat prescribing and queries. Processes of allocating home visits, clinical mail and how quickly it was actioned within the practice, appointment scheduling, drug monitoring and so on. You could apply this to any process. These were just the things that our practices that we work with chose to look at. As I say, we didn't say, you must do this. We said, what do you want to do? And these were the things they wanted to look at. The outcomes that they got, we feel and they feel, are things were safer. Certainly looking at prescribing, the very first event we ran, we didn't know how it would go. We didn't know how we would be received in the practice. But very early on in mapping the process, it became clear that every clinician looked at their prescription queries in a very different way. And in mapping it, we found that many of the clinicians were very reliant on the administration staff to do things that perhaps they ought not do. They were taking decisions that were perhaps best taken by clinicians. And just the fact that this was highlighted made the clinicians want to do something about it. And it led to a situation where one clinician in particular didn't really want to change. And there was nothing that I could have said, or anyone else really, to have him decide to change other than a colleague, a peer. And I thought, this clinician being a partner and another clinician being a partner, that conversation wasn't going to happen. But it did. One partner spoke to another partner and said, look, this isn't a criticism, but this is what we found objectively. And, you know, do you think that's safe? Are you happy with that? And he decided, well, it's perhaps not. What are we proposing to do? And he actually came on board and accepted the change that his practice were proposing. And I've stopped ringing this practice up now after 3 years. I used to ring them about every 6 months and say, you're still doing this? And after sort of 18 months, when they said yes, obviously we're still doing it, it's much safer, I thought, right, that one's stuck. That one's worked. Some things don't, but that, because it mattered to them and they felt they were so much better off, their partner said, why would I not be doing this anymore? It's so much more of a safer process. So it can work and it can be very effective. So the process can be more effective, we can improve flow, the patient experience can get better, not just in terms of shorter waits, but simple things we found, like laying out the treatment rooms in a way that allowed the staff to do their work better, and so that they didn't run out of things or have to go looking for things, meant less interruptions. If a patient's in a room and it's a fairly sensitive consultation, that's a better experience. So even the simple solutions added benefits. And of course, if the environment that you work in is less stressful, it's better for staff morale. So some of the critical factors: you have to involve everyone. The practice has to involve all of its staff. And for small organisations, this shouldn't be a problem. But so often we found that it was. In large organisations, we say, oh, communication's the big problem. We found in these small ones, the staff would say the same thing, which surprised me. But you can do something about it. You don't have too many people to get to in practices. Time. Time is the biggest constraint and the biggest factor for most of you, I think, and this is the main obstacle we came across, is, do we have the time to do it? But if it's important enough, you have to ask yourself, do you have the time to not do it? But there are things you can do. Keep the scope small and chop the amount of time out down to the minimum that you need. but you'll still need to take some time out to make some changes and improvements, I think. You can focus on improvements that release time. If you can release time, you can add more value to your patients through the time that is released. If you do that, you may be able to generate income depending on what you choose to do with the time that's released. One of our GPs in particular was very pleased with the amount of time he released from one of his members of staff so that he could add value in different ways. The partners are very important. The partners, they have the say in the practice. But the practice manager is as important. And we had cases where either a partner or a practice manager really wasn't that engaged. It could be a big block. So the practice manager is key as well. Facilitation is important. You might have these skills in your practice and that's great, but if you don't, where do you go to get them? That's why we ran our programme, really, to take what we were doing in hospitals and make it available in primary care. The tools and techniques we use should be simple. If we can't teach you them quickly, you probably won't use them. So we made adaptations to the stuff that we had learned to make it easier and quicker to deploy. And finally, PDSAs, it's not a one-off. It's a continuous improvement journey. And once you get on that road, you can't really get off, or you'll start to, at best, stop, or perhaps go backwards. And finally, just to kind of sum up, last year we did a type of Kaizen event that kind of went beyond Kaizen. A practice phoned me up and said, we're looking to build a new building. Can you help us to design it? Because we don't like the design we've been handed. So I said, well, we can try and help you design your building. And it started with all kinds of things, sketches, ideas. We made them think differently about what a practice could be and what it should look like and could look like. And we wanted them to break away from traditional thinking, which is what they said they wanted to do. You can see here one of the doctors and a colleague from the estates department in our organisation with a sketch of something they'd come up with. You can see it looks a little quirky. We've pushed them to say, well, what do you want your rooms to look like? And are you sure it'll work? And this is, I think this is the first version of the room that they said, we want to lay it out like this, and that's going to work. And then we made them make it as best we could. And they walked around it and played patience and played that, and they decided it wasn't going to work, because they kept bumping into things. So they relayed it out several times before they said, well, actually, we think we're going to go with this. So it needs to be this big and laid out this way. So I think they may have avoided some pitfalls in not jumping on their first assumption that we know what we want. And then we made them build a 3D model of their practice. We had their architect there. Their original design was very, very square. The final model that they built, in 3 days, start to finish, the whole event, they came up with this, an entirely different take on what a practice building could look like, designed around how they wanted to work to optimise flow and optimise the patient experience. And this was effectively done in 3 days, end to end. There was no long period out the front and no long period out the back, just can we come up with a draft design, something for us to work with the architect. So there are things that primary care can do with these techniques, I feel, and I hope that some of you will choose to look into them when you go back to your practices after the conference. So that is all from me, so thank you very much for listening. Are there any questions?
So we have about 10 or 12 minutes for questions. There are 4 microphones in the aisles. You're welcome to come up, or if you raise your hand, I'll be happy to bring the handheld mic to you. Start over here.
How are you? My name is Tisna Veldhuizen from the United States. I would like to know whether in your last example patients were involved in the design of the new practice.
Yes, we had 2 patients involved, a lady and a gentleman. And they were invaluable in a number of ways. One way that sticks in my mind very strongly, there was one person in the practice who was very resistant to the whole thing, very resistant to the whole idea of redesigning it. And it wasn't until after 2 days of this person being very first that a patient said, well, no, actually, I don't think that. I think this is going to be good for us. That person went, oh, and started to get, if not completely behind it, to stop blocking it. And there's nothing that I could have said, or anyone from the practice could have said to that person to make that happen, other than a patient. So yes, we have.
Hi, it's Brian Geller from Canada. We've tried similar things where I am, and we always hit the roadblock of budgets and senior managers. So I just wonder if you have comments on that.
I think that's a perennial problem in change generally. We didn't hit a problem with budgets with the practices. Management, yes. Some practices said this. I don't know why, because it was novel, perhaps. Yeah, we want to do that, but didn't really show with their behaviour that they wanted to do it. Budget-wise, the problem was more around where does the facilitation come from for a lot of practices, and having a programme that allows practices to access something that's affordable but can reach a large area. So I think that was where we had budget problems. My friend.
Hi, I'm Imran Tahir. I'm a GP in London. I actually run 15 practices in London. This sounds really appealing to me, but I've got two questions, really, if I'm allowed. One is about costing and funding. So who funds this, and how do the GPs get backfill time? And given that concern, and with the current NHS climate, how's that going to go forward?
How it goes forward, I think, will depend on how clinical commissioning groups set themselves up. They have, in all of the documentation that's come out, there's an onus on them to promote quality improvement in practices. It just depends how you read that. I read it thinking programmes like these may be of interest. Others may think differently. But I think it's up to clinical commissioning groups to have maybe their approach that they favour to have this kind of work go on. Personally, I would have a small number of improvement facilitators to work with all of the practices in the group. Most practices wouldn't run a lot of Kaizen events in a year, so over a group, a couple of people would be enough to facilitate the work, I think. And your first question is who funds it?
Yeah.
For our programme, we funded it in the PCT in the future.
That was one question. Well, there's another, if I can be greedy.
That's 3 by my reckoning.
You must have collected lots of data, because you mentioned metrics, and I didn't see much of that presented today. Have you got resources available that we can look at?
We do, yes. For each of the 8 events that we completed, we wrote a 2-page case study on what we did. And I have all of those in a single PDF, and if the conference will allow me to upload it to the site with the handouts, then people could access those and see what we did and what was achieved. Okay.
Hi, Rob Cheeseman from Liverpool. I'm a trainee in a very big eye clinic, part of which is a primary care clinic, which is basically just walk-ins and sort of like an A&E dedicated to eye problems. I know it's not quite primary care in the sense of general practice, no. But given the experience that you've had, I just wonder if you could maybe share some of that experience, really. And I've got what I would consider very good working relationships with people who are at the very beginning of the patient process of being booked into the clinic, having assessments and various tests done before they ever get to see a doctor. Yeah. And the nurses who do all that feel very frustrated about the processes, and they constantly tell me about the problems, but they don't feel like they have any outlet for those problems. They do also have a lot of very good ideas, and so I want to perhaps take it forward on their behalf to more senior people. But I wonder whether you've had any experience where you've helped facilitate a relatively junior person to work with and win over more senior people to that idea.
Or regardless of setting, Kaizen events have that effect. Everybody is equal in a Kaizen event. It doesn't matter if you're the top man or the lowest of the low. Your ideas are valid, and often it can be the more junior member of staff who comes up with the killer idea or says the thing that everybody's thinking but no one's going to say. They are an ideal format for that. And one of the things that surprised me in the first one that I ran personally was that the staff in this practice, they didn't really talk to each other. There was the doctor end of the building and the nurse end of the building, and the admin people in the middle of the building who argued with both sides of the building, but nobody really talked to anyone else. And we had a fabulous week with them where it was probably worth it just for the team building, where they just appreciated each other's point of view so much more. And some of the really good ideas that came out of that were from the admin staff and on the lowest bands. They said, well, why don't you do it like this? It's just sense. And, you know, for all of our education and degrees, some of the doctors went, yeah, maybe you're right, we'll try that. So it is a good format for breaking some of those barriers, I think.
I think we have maybe time for one more question. I have a question, so I'll jump in. Well, I was really interested by how you developed the program and the intervention. You went from 6 weeks to 4 weeks to 2 weeks, and it occurred to me that you were actually doing, while you were trying to teach improvement, you were doing improvement work on your improvement program.
Yes.
And so the question is are you still doing that? And if 2 weeks sort of worked, why not 1 week, or why not try a day, or so I guess my question is more of sort of like, where do you plan to go forward, and how do you evaluate the effectiveness and the goodness of what you've put together?
That's a big question. First of all, yes, I always felt that we should take our own medicine in improvement and improve our improvement process. So yes, you're spot on. That's exactly what we were trying to do. I worked on this with a colleague I seconded in from Nissan Motor Manufacturing, who have a massive plant in the northeast. So I drew on sort of lean resources in the area. I had lots of healthcare people. And one of the things that he would say is, you know, sometimes we used to do 2-hour Kaizen. So you talk about cutting it down. This is a massive plant that builds, well, now upwards of 500,000 cars a year, but they feel it's worth doing 2-hour improvements to improve that enormous process. So you can do what is required for the scale of the problem that you bite off. How I intended to evaluate this was, we got to a point where that was our model, and I'd written a research proposal. It was going to be the subject of my PhD research, and we were going to run the programme for another 2 years and put the evaluation around it like that. Unfortunately, the political landscape changed, so that didn't go ahead as intended. I now lead this regional programme that's hosted in Gateshead now, in an acute trust, interestingly. But they're very keen that we continue to work with practices. So if we can get enough momentum amongst the new clinical commissioning groups, I say let's resurrect it and make it better. Surely it's John and Iain's. Thank you.
Thank you very much.
Alrighty, we're going to switch gears and we're going to talk about Primary Care 3.0. I'm John Whittington. I work for the Institute for Healthcare Improvement. I'm a family physician / GP by training, and my colleague Iain Rutter is a GP also. I want to put this in context of how do we start on this work. Iain and I both work on the triple aim for IHI, and we'll put a plug in. We'll actually talk about the triple aim on Friday, Iain and I. Part of the work of the triple aim, though, has to involve primary care. And don't think doctors when I say primary care, think much more broad-based than that. So back in 2010, we spent some time trying to rethink through primary care. At that time, we were doing it both in support of the IHI, but also in support of what we thought were going to be, if you're from England, GP commissioning groups, which have now morphed into clinical commissioning groups, which are now still a ways out or in various processes. So we did a lot of this work just to help us rethink through what it would look like. So that was, I wanted to get the context of that. The way we're actually going to do this talk is I'll start out with a theoretical aspect, and then I'll use organization South Central to talk about how they might have looked at this particular problem. Then Iain will talk about it from his own practice sake, and then we'll bring in one other triple aim site that's done some nice work and share that with you. So understand the model, and then we'll use these 3 examples. So primary care 1.0 was the idea, and I think really primary care 1.0 ran through the 50s, maybe the 60s. 1950, 1960, where what we were really focused on was the acute intervention. People had pneumonia, we gave them the drug, we took care of the problem at that time. So the main focus was prevent death. Primary care 2.0, I think, is a lot of what's going on. In the United States, I would call that the medical homework, developing this medical home. It's the idea we're going to do a great job on managing acute care, but we're also going to be much more proactive in managing chronic disease. But primary care 3.0 is the idea that you're going to optimize health. You're going to optimize human potential, and I'll share a little bit more what I mean. So here's a nice example from South Central about how healthcare, quite frankly, is in a lot of places, but how it shouldn't be, where everything is centered around one more thing for the GP to do. That's the provider in the center. It's like one more thing they need to do. So keep that model in place. When people started doing it in the United States, there's been this push, and in other places there is a push on really rethinking through primary care 2.0, which again is how to do great chronic care. And we think the primary care 3.0 model is built upon that. So it's about the care team development, thinking about populations, working on quality improvement, efficiency, etc. So those are some nice principles that we've actually seen in place. Now, just to tell you what the world looks like, if I actually had to put a number to things, I would tell you the United States, we are probably a 1.3 model at this moment in time. Just getting past acute care, just organizing ourselves a little more around chronic care, but still a long ways to go. And then just as I've had the opportunity to look at organizations around the world, just picking on the English system right now, I'd say they're more like a 2.4 model. And again, you know, when you say that, you can find organizations that are closer to the 3, and you can find organizations that are closer to the 2, and I could find high-quality organizations in the United States too. But I just think there's a long ways to go. Remember that one model that I just showed you a second ago where everything goes through the doctor? But think of a new model where you have this team that's deeply involved, and the providers, the doctors, the others, caregivers, are only parts of the team, and you're really trying to do parallel flow. And that's the illustration here. So here's primary care 3.0 in a nutshell. Here's the, you know, whenever anybody ever gives a talk, usually there's about 1 or 2 slides that are important. So from the theoretical standpoint, here's the important slide. First of all, it's this idea that we talk about vertical integration. Now, vertical integration really refers to the healthcare system itself. How do you integrate primary care, secondary care, tertiary care? How do you actually coordinate them? That's the idea of vertical integration. But the other part that's a key player is, and you could say, I'll call it horizontal, but another way to think about it is how do I integrate the community? And I'll give you clearer examples when I start talking about a case here in a moment. But that's care across dimensions, such as behavioral health, social well-being. This is part of involving the third sector in your areas. How do you actually do that such that you actually have a flow across the community? That's a key thing. And then lastly, the part about longitudinal life, how do you actually think about that for various phases of a life? Let me show you what I mean by that here. This work, the first time I ever heard about healthcare 3.0 was coined by this man, Neil Halfon from UCLA. He's a healthcare researcher, great thinker, and he talked about, and he's a pediatrician by training, and he actually talked about these 2 different curves here. What these curves represent are life's potential. We actually think, there's literature start to show us that the battle is won, I'll call it between -1 and 5, okay? So in the womb, to first 5 years of life, there seems to be more and more literature that's showing that other diseases and other issues that will happen in life are being predicted in those early phases. So it's not just the genetics, it's the development. So which trajectory would you rather be on, the lower curve or the higher curve? There are programs within communities, like in English, I think it's Sure Start, is that what you call it?
Sure Start.
Yeah, Sure Start is an example of how do you try to maximize that 0 to 5 potential. The point about this is to say primary care is about maximizing life's potential all along these curves. So at the beginning, but other aspects of it. Let's use a case. So here's a case, and I'll just read it since hopefully you can all see it. But Frank is a 79-year-old widower with chronic obstructive pulmonary disease, heart failure, and diabetes. He lives alone. Frank is very anxious, and he's often very breathless and feels unable to manage. He has phoned the practice of his primary care physician on several occasions, requesting a home visit, and over the last year has frequently been taken to the local emergency room, or A&E, is how you'd say it, after he dialed 911. That's what we dial in the United States, but you dial something else in England. Anyways, he has been admitted to the hospital on 7 occasions, this is the best part, in the last year, and now keeps a small suitcase packed by his chair. Frank is that 1% of the population that's spending 25% of your resources. Think about Frank now. Think about the models how you would actually take care of Frank. And I'm going to challenge you. You think about it now, but I'm going to challenge you with a 3.0 model. Just trying to make it more practical than the theoretical stuff that I was talking about. So Frank, in a 1.0 world, what would you do? You treat the exacerbations. In the 2.0 world, you try to manage the chronic disease. But in the 3.0 world, you realize that the inadequacy of just treating the exacerbations and managing chronic disease. You're really working with Frank as a partner. So in a 1 or 2.0 world, what's Frank's diagnosis? COPD, congestive heart failure, diabetes, okay? And who's Frank's health providers? Well, primary care, cardiologist, pulmonologist, etc., etc. Frank's got a whole list of people. At least Frank's not lonely, because he's making all these healthcare visits. See, what we've done with Frank, and lots of Franks, is we've medicalized their treatment, if you will. We figured out ways to actually think about them and say, you have X, we'll do Y. We'll do Y. We do Y to you, in a sense. But what we're really discovering with people like Frank and so many others is it's not the medical diagnosis that's so important. It's all the other stuff. They don't live with us. They live with somebody else or live in some other social context. So we've got two choices to make with our financial constraints. We have two choices we can make right now. We could say to ourselves, we can't waste resources, so let's just concentrate healthcare on what it can do best, okay? Which might be just treating the acute illness and working on breakdowns. Or we could start to think about how do we redesign healthcare such that we move away from the medical model, diagnosis and treatment, so something incorporates the medical model, but some social psychological model also that's built in with it. You know, this is a nice curve. What this comes from, this is my colleague Doug Eby. And oh, by the way, initially Doug was going to be here with us at this call, but the South Central Foundation won this very prestigious award in the United States called the Baldrige Award. And the award of that is actually this week. So it was a very worthwhile reason why he couldn't be here. Because in our country, to get the Baldrige Award, you have to be the elite of the elite. It's the top of the awards from a quality improvement standpoint. But what is trying to be illustrated here is who has control? In other words, think about a patient and control. And most of the time in our lives, we, the patient, we, the family, we have the control. It's only when I've been in a car wreck or have an acute MI or one of these horrible exacerbations that healthcare has the control. And that's all you're trying to illustrate is when the acuity is low, in ordinary life, if I can get up and walk out of the room, we'll call the acuity low. It's only when you're in the really high acuity aspects that healthcare has much control. So it's rethinking who has the control. So a different look at Frank. Take a moment. What are the diagnoses now? Anxiety, loneliness, isolation, insecurity. That's the primary diagnosis. And the secondary diagnosis is what we do. When Maureen used the one slide today, which is the rainbow slide, determinants of health, and we said to ourselves, well, where does healthcare? It was just a minor player in that. So let's not confuse ourselves. There is a role for healthcare to play, and we'll see some good illustration later when Iain talks about it in our talk. But it's trying to blend these two things. It's going back to the model I said. It's terrific healthcare, vertical integration, but it's also this community integration, and it's also then, even in Frank's situation, how do you maximize his life's potential? And then what are the interventions you do? Well, some level of coordination, integration of the primary care team, work on the motivators. So the real world of healthcare isn't like I did for, I mean, honestly, I did this stuff for so many years. You come in, and Iain will say the same thing. If you start talking to me and I can't figure your diagnosis out in about 10 to 20 seconds, I know I'm in trouble. But that was my job, figure your diagnosis out. Now what are we going to treat you with? What's the pills, okay? And then I would think later on, oh, you bad patient, you non-compliant, you didn't follow, okay? And reality is, what were the issues, the other issues going on? How well do we know their life? Now, as family physicians, we get to know people's lives fairly well over the time. But how well were we incorporating the other community aspects of things? Now, I want to say on the primary care 3.0, or even the triple aim, there's nothing new under the sun. It isn't like people aren't starting to think about this. People have been thinking about this for a year. It wasn't like people weren't thinking about the triple aim before IHI coined it. But what we're trying to do is to say, but how could you intentionally move yourself to a new world? So Frank's in control of whether he picks up the meds, whether he uses his inhalers, whether he eats, drinks, smokes, whether he exercises, etc. So how would we affect those things that Frank's in control of? Well, some form of behavioral modification might be helpful. The one technique that people use is motivational interviewing. The simple way really goes back to what Maureen was talking about, not what's the matter, but what matters to you. And maybe even asking a question even deeper. Iain and I had a terrific conversation after that call, which is say, why does that matter to you? Because that might get at an even deeper issue that's going on. So my challenge is, can we design a perfect healthcare system so that when we see the patient in that 10 or 7-minute visit, we can get the job done? I don't think so. We want to make that as good as we can, but we've got to think about a whole system. So success for us in healthcare depends upon our ability to affect choices. And relationships are going to be key in this. So I think there's two critical factors, really, when you start to think about it. How confident was Frank in managing his own healthcare? And how had we helped him with the sense of loss of control or anxiety? In that relatively bleak picture I painted for you, the only control Frank seemed to have was to have a suitcase ready and the phone by his side. It seemed like there was another option for Frank here. Would have been having a clear care plan, a clear ways for him to access care. It would have probably been, with Frank, we could have afforded this because he would have been such a high-cost person, having some sort of case management tied to primary care in a much closer way. And as we think about Frank's a great illustration. Now, Frank would be a very high complex because he had some terrific medical issues, but he also had he was isolated, alone, some terrific social issues. So Frank is really one of those really complex people. If he had let's paint his picture differently. He's got the same medical things. He lives with his daughter, and his son is a doctor, okay? And lives with the daughter, and his son-in-law is the doctor. And they helped manage the situation. That was actually my mother-in-law. She lived to 98, and my wife managed the case all the time, and I ran interference on the medical thing, and we helped manage her, and she did quite well. But she was high complex on the medical side of parts of her life, but she was low complex on the social side. So that's why we have to start to think about the social variation as such an impact for us. And so as we go back to the primary care 3.0, it's about how to coordinate healthcare, how to coordinate community resources, and then thinking about the individual we have in front of us and how to maximize that individual's opportunities. So, but this thing didn't come out of a vacuum. What are we taught as healthcare professionals generally? Signs and symptoms, differential diagnosis, ordering tests, definitive diagnosis, etc. This is what we've understood so far, but our challenge now is to think differently. And I think we've been thinking differently. I think a lot of what we see right now is different thinking, but what we're trying to do is push us along to really actually get closer to this type of support anywhere in the world. So a different look at Frank from standard of how does South Central, because this organization up in Alaska, how would they actually do it? Well, first of all, right now Frank has many health experts giving advice and prescriptions. Frank's really making all the critical decisions. Frank's share of medication costs. Maybe in the U.S. you might have an insurance product, and an insurance product may or may not pay for all your medicines. Frank's got a variety of influencers. So let's pretend you're South Central and Frank's just been hospitalized. How do we actually start to change it differently? Well, they would put in a case manager. They would get the primary care team involved. They would make sure that the medications were provided, and they would learn about Frank and his story, identify his motivators. Upon discharge, they'd have some form of home health actively being involved with him. They would actually front-load it. What I mean by that statement is, when do people get readmitted? Well, often in the first 30 days. Actually, often within the first 2 weeks on these high readmitters. So when's the most important time to send home health out? After a week or 2 weeks? No. You want to get those visits early on in the complex patients, and then you could start to lessen them out over time. That South Central is an Alaska Native, indigenous people, so they actually have an elder program, part of the tribe itself. They'd also get them involved with health ed and wellness and phone call follow-ups. That's at the discharge, but they'd also be planning to receive him into the primary care setting. So they'd have coordination with home health and the elders, medications. They would actually have the pharmacist see him on the day he comes. And they would actually have the pharmacist be working with him on that day he comes. They also have a behaviorist in the practices, so that behaviorist might be involved with Frank on that particular first visit. So there'd be a lot of motivation going on in those first visits. They would work on a customized encounter form for Frank and personal clinical information. The point of all of this is to think differently, to actually say, what would primary care 3.0, and where are we, wherever you are right now on this journey, and what's the next step to move it along? Let me go ahead and switch gears now, and I'm going to have Iain Rutter talk about his own practice, and then Iain's going to talk about another organization that's been part of the Triple Aim with us.
Thank you, John. We got involved in this journey in 2000 when we became involved with Pursuing Perfection, which was the originator of Triple Aim with IHI. And at that time I was the chief executive of the PCT and a jobbing GP. So I think I'm probably as near as you're going to get. I was doing 2 days a week of general practice and 3 days a week as the chief executive. I'm the chair of a CCG group. And as John mentioned, there are two other really big issues that need to be addressed if you're going to move to primary care 3.0. The first one, which I'm going to talk about relating to my practice in Bradford in the wider context, which is about vertical integration. And then the second is about how we really address inequalities and narrow the gap of inequalities between the different segments of our population. Bradford, since 2000, has been a regular saver of millions of pounds of healthcare money and has never overspent. And one of the key reasons is that we've vertically integrated major chunks of work out of hospitals. In our system in England since 1948, we've had a huge advantage with the GP and the gatekeeper system, but a huge disadvantage that the only way you can get specialist advice is in a hospital setting very broadly. And the challenge I think that we have is how do we shift that specialist care out into community settings and with it organise care in a very different way. No, wrong way. We're a very simple small practice, but we're one of a network of small practices that are moderately average sized practices in the UK, so there's nothing special about us and nothing special about the practices around us, but in my area about 60 of us now have a special interest in some specialisation, and large numbers of consultants and specialist nurses and specialist physiotherapists and specialist optometrists and specialist pharmacists are working in community settings doing a very different job to what they did before. My practice, that's a sort of range of extended services that we offer. My neighbouring practices are offering a range of extended services very similar to this, but not the same as this. So we're complementing each other. So I refer down the road to a specialist eye service run in a neighbouring practice, for example. They refer to me or to us for cardiology. I'm just going to use one example of cardiology just to illustrate the point, but the point should be made that this is across the board. So actually, the savings financially and the quality improvement is not just in one area, the area I'm going to talk about, but is across the piece. We've not done this in isolation, so we see ourselves as a hub, a locality hub, of our local district general hospital, and we work very closely with our local district general hospital, but like other practices, we employ consultants, we employ specialists. This is a traditional, in England anyway, means by which a patient is seen for cardiology or for any problem. And every arrow is a weight. Every arrow is a disaster. This system is organised and geared around medical care and medical staff. It's not organised around patients. If you really look at people who have really made this drive very effectively in Yon Shipping with the ESTA model, Lois model in Care Oregon, this is the same principle. How can we redesign this system around the patients? And so we've shifted care out, cardiology care out of the hospital, and we're now on the national choose and book system. So if you are a GP in the UK here and you want to refer your cardiology patients to us as a plug, you can do so. And what we've done is we haven't moved the existing model into primary care. We've fundamentally redesigned the model and taken from the first speaker the lean principle and taken out all the unnecessary steps, and actually taken out large numbers of steps that are given and taken as normal practice. You see somebody in an outpatient, well, as I'm about to show you, many of the patients that are referred to us are never seen. We triage all the patients, and many of the patients, and this is true in any of the specialties that I'm talking about, many of the patients that we are sent don't actually see anybody. They actually go directly for tests. Those that are seen are actually seen by a GP with a special interest, and a very, very small percentage of patients are actually seen by a specialist. And when people have tests, we refer people back to their GP. So we're now starting to work in a team across primary care, other practices, ourselves, and with the hospital. And we're not actually working our way in individual silos. We're recognising that we're part of a large, big team. And that's just sort of an example of the things that we're doing. And the costs, this is just an illustration, but the costs are very dramatic. You save large amounts of money. I was in a meeting yesterday because we're a different half of the Department of Health, and I was sat next to an ophthalmologist who was saying if he does a retinal lasering in outpatients, it costs very little, but most of it's done in a theatre with large numbers of people all around, which just do not need to be there. But actually, nobody is fundamentally challenging the basis of that type of system. And what we've done is fundamentally challenged it and said you can do it a lot more effectively, a lot cheaper. And another example, this is in urology. If you have blood in your urine, the first thing you need is not an outpatient, you actually need a flexible cystoscopy. So in my area, if you have blood in your urine, the first thing that happens is you get a flexible cystoscopy in primary care in a week. And if actually you then have a bladder tumour, you put on to the next waiting list for the urologist to operate on you next week. So the first time you see the urologist is actually when you're in hospital awaiting surgery. If you don't have a bladder tumour, the next commonest problems are a renal tumour, and if you need to diagnose a renal tumour, you need a CT scan and an ultrasound scan. In a conventional system, you have those on separate days. We do this for breast conditions. Why don't we do it for everything? The sort of one-stop shop principle. In my practice, we have an operating theatre, and I operate, and I'm a plastic surgical gypsy. We do many more things than you would normally expect in a primary care setting. You talk to the patients, they love it. We've had one infection in 3 years, and we operate on about 40 people a week. So that's the summary, which is all about really doing this in a very different way and properly integrating. And this potentially can save you really quite large amounts of money to facilitate you doing some of the more sexy things that John was talking about. This is an example of another element of primary care 3.0. How do you really address and reduce the gap of inequality in health? What we've got in the UK with the QOF is actually a very effective chronic disease management programme, but actually, is it? Because actually it hasn't reduced inequalities in health. And why not? Because we're allowed exemptions and we're actually allowed targets, which means that we don't have to address the most hard-to-reach groups. In Bolton, they actually decided that they would address this problem, and cardiovascular disease mortality is very variable in their area, and this is the work of Stephen Liversidge. But basically, the darker the red, the more likelihood you are to die of cardiovascular disease. And the life expectancy gap between those different boroughs there, between the most pale colour and the darkest colour, is 15 years. And actually the gap, England gap, is 2.3 years. And the biggest contributor to those are the three things at the bottom, of which cardiovascular disease is the main one. One of the problems that you have when you start involving and working with individual practices is that the claim that my practice is hard and more difficult to reach, the demographics aren't the same as somebody else, so how can you possibly expect me to get the same results? What Stephen did is say, okay, well, I'm going to peer cluster all the practices in my patch together with like-minded peers. And when he did that, you can't see in detail the individual practices there very easily, but it doesn't matter. These are now bunched together with this different demographics and deprivation. And what you then start to see pressed it too far. Are those different clusters. He then combined this with multiple visits by trained people working within the PCT to support the differences that he was finding. And he invented something called his logarithmic incentive scheme. So unlike the English QOF, where you can get all your money for relatively easy targets, you only get some incentivised financial reward as a practice if you reach the most difficult to reach group. If you don't get that, you get very little. I'll leave that slide because we're running out of time. But basically, those are the averages of the different peer cluster groups. And those averages are very, very similar. But if you could see the detail behind it, you'd actually see there's a wide variation in the performance of the individual practices. Not unexpected, because that's what we see, large variation, even within the individual peer clusters. What he was able to do was to put and facilitate the individual peer clusters working together with his team to actually address and reduce that clinical variation. And before he started to get involved in doing this, those were the sort, with the practices, that was the sort of result they were getting in Bolton and the Big Bolton Health Check, which was going out, excluding primary care, into a community-driven approach to try to address the issue. By combining primary care and the community and his logarithmic incentive scheme, those are the sorts of results he was able to achieve in terms of identifying that group of the population that were most at risk of cardiovascular disease. And fundamentally, he's reduced the mortality rate in Bolton. those are the myocardial admission rates to Bolton Hospital. That's the mortality rates falling. And fundamentally, he's reduced that inequalities gap by 1.8 years and down to 11.9 years. These are really quite stunning results because nobody else has been able to get anywhere near this. Thank you very much. That's the end of my bit of the presentation. John, and we realise that we're running out of time here and people want to go for a coffee, but John and I will stay around and we'll answer any questions through the coffee break if you want to ask us any questions. Thank you very much.
We have probably 5 minutes or so for general questions if anyone would like to address them to Iain and John.
Hello, my name's Anita Jolly. I work for the BMJ Group, and this is a question for Iain. I think that's fascinating, the case study that you've put up there, and knowing how difficult it is to reduce inequalities in health. And my question to you is, what was it about bringing the practices together into peer groups that really helped drive that change?
Well, I think John might want to come into... Is this on? John might want to come into it as well, but I think basically what he was able to overcome was the idea from clinicians, and I'm one of them, that somehow my population is more difficult and therefore it's impossible for me to deliver, because immediately as he made that information transparent, it was quite clear that there were other practices, very close neighbours, who in this particular example were achieving where the practice concerned was not. But he's extended this beyond cardiovascular disease. This is across now all chronic disease management, and he has these clinical dashboards across all disease management. But he didn't just leave it at chronic disease management. He applied the basic IHI, PDSA cycle change approach with health interventional trainers going into the practice to facilitate helping people to make the change. Because fundamentally, people, once the practices realised that there was a problem, were very keen to address the issue. And it gains a sort of momentum and a speed attached to it.
Yeah, I mean, the only thing I'd add is what he was able to achieve with this was first of all, clinical variation is our friend right now, in the sense that once he put the peer clusters together, people could no longer say, my patients are sicker. So if you're in the posh area of town, you probably do have healthier patients. And if you're in the most deprived area of town, you probably do have sicker patients. The good news, though, once you if you study the data, it's just, it's hard on the slides, but if you actually look at the slides closely, what you'll see is that there's always someone within the peer cluster, they were big enough, who actually was doing very well. And so then he could point and say, well, look at so-and-so. What can we learn from them? And that took away that whole argument of my patients are sicker, because they weren't. They weren't any sicker than the peer clustered group. But the good news was there was clinical variation. And then what they were actually able to do over time is really narrow that variation by really going back to the earlier presentation, which is how do you actually start to do quality improvement within those offices? How do they learn? And it wasn't so much of I mean, there were financial incentives, and that was a motivator. But it also was, how can we come and help you work together on that in the redesign and the practice? So that was the essence of what went on.
And I think the other key message from that was that before he involved the practices together with the community, because the community was activated through the Big Bolton health check, what they actually found is large numbers of the worried well were repeatedly having their blood pressure checked. And they were still missing the hard-to-reach groups.
Great. I'm Jonathan Sargent. I'm a clinical director of Brighton Integrated Care in England. Very interested to hear about your primary care 3.0. We just started working on a similar idea, and the sort of question is that in the UK, the general practice of a 10,000 patient practice is focused around delivering care to that widespread group. Is it worth actually creating a new form of general practice for these particular high-need individuals and put them all in one practice and actually have much more focused customer care for that group of people.
I think there is some merit in some examples. So certainly when I was involved, and it still continues to this day very successfully, one of the high-risk complex group are the alcohol and drug users. And putting them all together and giving them a very different holistic approach to their drug abuse is a very successful way, I think, potentially in reducing inappropriate use of hospitals and A&E and general practice. I do think that there are huge merits in terms of population size now with CCGs to develop some of the models that you're talking about, because 10,000 is too small. And personally, I think the days of primary care at 5,000 to 10,000 are potentially over. If we want to be that radical, I think it's going to take some time for GPs to move away, not least of which our payment model in the UK. But I do think that potentially, if you're going to do what potentially is being achieved now by South Central, it's because they've got a much bigger population size and a bigger mass of other people involved besides general practitioners. And a small general practice like ours is never going to be big enough to have that suite of people working very effectively. And we've been playing around this for a long time, but fundamentally I do think the models will start changing. And going back to my first presentation, I think the model needs to change. Why are hospital consultants employed in hospitals? You know, why fundamentally? And actually, if you go elsewhere in the world, you go to Kaizen and they're not. They actually work in primary care settings, and they're not actually allowed to work in hospital. So, you know, we have some sort of very rigid stereotypes that we've sort of got fixated on since 1948, and I think potentially now the exciting thing about CCGs for me is that we might start to see some of those models break down, and people like you are at the forefront, so tell us what you're doing.
Yeah, no, well, we're trying to build a model of general practice for about 3,000 people, and looking at how those people are complex social, psychological, and physical health problems, and you actually combine the funding for that with take it out of GMS, which is the way in which they fund general practice in the UK, and take some of the money from the hospital and some money from social care, and you deliver a completely new service. But the key, I think, is to get the patients to believe this is their practice. Okay, it's not as close to their home as it maybe have been if it was down the road, but it's the key of having that ownership and feeling that that's the place that they turn to access care and have the faith that they're going to get good care from it.
One follow-up comment I would make is we see some work in the United States along these lines called hotspotters, just looking at the complex, how would you analyze it? The only thing I'd say is, great, test it with 5 patients, okay? You could take 5 patients, you could put them in a situation, you could try it out for a while before you actually ramp up, learn the bugs out of it, and go from 5 to 25 to 125 to 600 to, you know, 3,000. You could actually do it in multiples of 5, and that's what we actually preach is when we think through these things, how do you ramp up and how do you test on a small scale but then expand quite a bit over time?
So, thank you once again to all 3 of our presenters. We'll move to our break.